All right, welcome. This is for OB Boot Camp and talking about the postpartum patient with the assessment and interventions and education, because it all kind of goes together. That's what OB nurses do. Mom baby nurses really specialize in teaching. We have to get these families ready to go home so that the moms can take care of themselves and the family can take care of the newborn. So there's lots and lots of teaching that goes on with this. The first is the postpartum assessment. We use the mnemonic BUBBLEEE. And first, is breast. And I know that this is a terrible picture, but I like it because this is how we palpate the breast with the flat of the hand. Okay, so the flat of the fingers, not the flat of the hand, but the flat of the fingers. And you're going to just palpate around the edges. What you're feeling for is to feel if you can feel any of the milk ducts starting to fill. You will notice if nobody's milk, if the colostrum isn't coming in yet, then the outer sides of the breast are going to be soft, non-tender, no lumpiness. If they are starting to fill, they'll be obviously firmer. And it usually starts on the outside of the breast. We're also going to look at the nipples for any bruising, cracking, bleeding, blisters. Okay. If you see those, baby is not latching or attaching to the breast correctly, and we need to intervene in that. We do not, this is driving me crazy. We do not do the actual assessment palpation piece. We don't need to look at the nipples and feel the breast of someone who is not going to breastfeed. So we're doing that on just the breastfeeding mom, but we still have education that we need to do for the bottle feeding mom. So engorgement is something that happens because of mom's hormones, and it happens whether or not mom is breastfeeding. So usually to what degree it's breastfeeding or not, but it can happen to the mom who's not breastfeeding. And so we don't want it to take her by surprise. Okay. So engorgement is, if you look at the pictures, the engorged breast is swollen. And not just because the milk ducts are filling with milk, but because hormones are just making that whole breast swollen and tender. So if you've ever had a period and you've had that rush of hormones and your breast feels swollen and uncomfortable, that's a little bit of what engorgement feels like. So, and mom can go to bed and sleep for a while and wake up, and she will have a couple of hard, warm cantaloupes on her chest. So it can really, really take her by surprise. So engorgement is something we need to teach on. For the bottle feeding mom, let them know that it starts at 3 to 5 days. And there's kind of a hormone rush. The other thing that starts at 3 to 5 days, postpartum blues, also caused by hormones. It usually lasts 24 to 48 hours. We used to say tight bra or bind breast, but really we just need a nice snug bra on. You don't want it too tight or they can get mastitis. But the big thing is, so wear a supportive bra. Don't let the breast fly free. You don't want to stimulate the nipples. So even when you take a shower, you shouldn't let the water spray directly on the nipples, because any stimulation of the nipples will mean that the breast will start producing milk. So for relief, mom can put cold packs on, use ibuprofen, also cold cabbage leaves. If you have washed cabbage leaves, put them in the refrigerator. And actually, if she pulls them out and kind of mashes up that big vein in the middle of the cabbage leaves, there's an enzyme that is actually very soothing for the breast. And then she can just tuck them in her bra. So cold cabbage leaves are a thing. So those are the things that you need to teach the bottle feeding mom. You have to know this when you first day when you come on the floor. So breastfeeding mom, same deal, usually starts around 3 to 5 days. Um, Hopefully sooner, closer to the 3 days because baby will have been breastfeeding. So it again lasts about 24 to 48 hours. You want to wear a nice supportive bra. You want mom to feed every 2 to 3 hours. So that isn't different. But in between feedings, she shouldn't stimulate the nipples. So she shouldn't let the water run in the shower, do anything to stimulate the nipples at all, because that's going to just make more milk. More. And so sometimes mom's breast is so swollen and tight that the baby can't latch on and get the whole areola in their mouth. So what she wants to do is put warm packs on before she nurses and kind of massage the breast tissue to try to bring down that milk and loosen the breast up. She can hand express, squeeze some of the breast milk out so that the baby can latch on correctly. But if she uses her breast pump, it's going to be too much, and then there'll be more milk than the baby can handle. So and then you just have this imbalance of engorgement lasting longer. So nursing breast milk is supply and demand. The more demand, which starts at the nipple and areola, the more demand there is, the more milk that's made. So after breastfeeding, she can use cold packs, and she also can use ibuprofen. All right. So, and then this is not a good thing. Uh, Mastitis is an infection in the breast. And usually it's unilateral, so it's just on one breast or the other. It is where probably a clogged milk duct gets infected. There's a warm area on the breast, usually right where that spot is. She may not notice, but she will not feel the greatest, kind of malaise, just flu-like symptoms, low-grade fever. And it's an infection. So she needs to contact her provider and take antibiotics. She can continue to feed on both sides. That's okay. But leaving it alone and just thinking that it's a clogged milk duct is a bad thing, because I have known people who've actually had abscesses in their breast and had to have surgery because of mastitis that they let go. So, okay. All right, so now we're going to assess fundal height. So we did breasts, all of that was for breasts. Now we have the next thing is U on our BUBBLEEE, and that's for uterus. And the fundus is the top of the uterus, and that is what we're assessing for. Now, before we do this part of the assessment, you want to be sure that mom's bladder is empty. So what I usually say is, when it's time for you to go in and do your assessment, which, by the way, you will never do by yourself. You'll always either have a faculty member or a nurse with you. It's a very intimate assessment, and it's for your protection to have somebody with you. Okay. So, so when you go in, these are healthy people. You do not need to do a thorough head to toe. You want to listen to the lungs, listen to the heart, and listen to the bowel sounds. So I may send you in there to do those things, and then also to ask mom if her bladder's empty. If not, give her a chance to empty her bladder. and you get those things done. And then I come in and you start your BUBBLEEE assessment. Okay. So everybody needs to be lying flat to be checking fundal height so that we all get the same readings. If mom's head is elevated at all, it's going to change where that fundus is. The other thing is with non-dominant hand, you want to support the bottom of the uterus. So just right above the symphysis pubis, because you can move that uterus all over the place if you want. So you want it to just stay where it's at. You have to be sure you're not pushing up on it. So that is important to always support that lower uterine segment. And then I usually start above the umbilicus and just kind of walk my fingers down. That uterus is very sore. Mom pushed a baby out of it, or has an incision on it and on many layers of the tissue, the uterus, the tissue, and the skin. So it's really important to go gentle. If mom was bleeding, we would definitely be more aggressive and massage it, but we are not anticipating that, right? So we just walk our fingers down and we figure out where the top of the uterus is, the fundus, in relation to the umbilicus. And I'll show you in a minute how we chart that. But what do we need to teach mom? We need to teach her about involution. We don't have to call it involution. You can just say it's the process of your uterus going back to its pre-pregnant state, and that we feel the fundus. We offer her a chance to feel the fundus. Some really like it, some don't. It goes down 1 finger width a day. After 10 days, she's not going to feel it anymore, but it's still healing on the inside for 4 to 6 weeks. So she doesn't want to put anything in the vagina in that amount of time. So no tampons, no intercourse. So fundal massage helps that process move more quickly. Also, if mom is bleeding more than she should be, massaging it will help slow that bleeding down. Now, if we palpate that fundus when we're looking at the fundal height and the fundus is soft, it should feel like a softball. But if it's soft and spongy, we will massage it vigorously. And we'll also at the same time look at the vaginal discharge or the lochia that she's having, because a soft uterus is a bleeding uterus after delivery. And so we want to massage that. Now, if you think about this, massage is CPR for the uterus. So if the uterus is bleeding, that is one of the biggest risk factors after delivery. We need to massage vigorously and call for help. Okay. So to chart, and this is universal everywhere, to chart where we found the fundus, we are going to relate it to where the umbilicus is. So the umbilicus is stationary, it doesn't move. That uterus is moving. So the umbilicus is always you. Right after birth, when we take out the placenta, usually the fundus is 3 centimeters under the umbilicus or finger width. Then on the day of birth, 8 hours afterwards, by 8 hours afterwards, it's usually at the level of the fundus, and then it starts with the involution. So if it were above the uterus, above the umbilicus, it would be 1. So the 1 is saying the uterus is the number, is above the umbilicus. So 1/U. Uterus at the umbilicus is U/U. If the uterus is where our expected findings under the umbilicus, it's U. The umbilicus is the uterus is the one under the umbilicus. Again, the umbilicus isn't the thing that's moving, it's the uterus. So, any questions about that? You can ask me later, but that's how we measure it and that's how we chart it. Okay, so if we have, if it's above the umbilicus, it should be midline with the belly button, with the umbilicus, and it should be at the umbilicus or below. If it is above the umbilicus and displaced to the right or the left, the most common culprit is a full bladder. Now, mom may tell you that she doesn't need to go to the bathroom. And if she's had an epidural, that is that last area to really wake up and have sensation. So she may just not be feeling that her bladder is full. So we want to check that out. Again, when your bladder is holding your fundus up like this, it will cause it to stop contracting, and then we have bleeding, and then we're in trouble. So sometimes if she can't empty her bladder all the way, we may have to do some straight catheterization of that bladder until it wakes up all the way. We may do some bladder scanning, but we've got to get that bladder emptied. And yeah, okay. So that's our uterus. Our second B is bowels. You did the auscultation already, and then we're just going to ask questions, right? There's not a lot more that we can do, but it is a precursor to, it's definitely a precursor to our teaching about bowel movements. So these are the questions that we ask. We are going to ask, is there any nausea and vomiting? Okay. So does she feel like she's emptying her bladder? Oh shoot, we're in the wrong place. Of course. Here, we were in bowels. Okay. Not any nausea, vomiting. When was the last bowel movement? And you can say, have you had a bowel movement since you delivered? Usually moms, when they go into labor, it kind of has a laxative effect. They'll usually have loose stools just before they go into labor, all from the prostaglandins. Also, she will, if the bowels aren't empty, a lot of times when mom is pushing, she will lose stool also. So it's not, and then she's not eating a ton during that time. So there's not a lot of BM in there probably. So it's really uncommon is what I'm trying to say. But her bottom hurts. So it is uncomfortable and it's sore. So we want to give stool softeners. Usually they're getting stool softeners in the hospital at nighttime. And we want to tell them that, yes, you can take those stool softeners when you get home, drink lots of water. Most important thing is if you have an urge to have a bowel movement, don't hold it in. The longer you hold it in, the harder it'll get. It'll be more uncomfortable. Another question, probably not in that order, would be, are they passing gas? And just, those are just the normal GI questions. So, but we want to be sure we talk about the stool softeners, that we don't hold it in, and drinking lots of water. Saying fiber and raw vegetables, not always a cool thing because they can affect baby while mom is breastfeeding. So we do have to be a little careful about that. Okay, for the bladder, do they feel like they're emptying completely? Obviously. We don't do a ton of INO, but after mom has delivered, we want mom to have emptied her bladder. So 2 post-delivery voids. of at least 250 mils each. So we have a hat in the toilet, and until she's gotten 2 voids in a row that are 250 mils, we will keep measuring those post-delivery voids. So, and we may again do some bladder scanning, etc. So we want mom to attempt emptying her bladder at least every couple of hours. She needs to know what the signs of a UTI, urgency, frequency, pain, cloudy, smelly urine, all of those things. So she needs to know what that is. Most of these moms, if they've had an epidural, then they have had a Foley catheter. And so they are at risk for a urinary tract infection. Some of the times, some of the reason that they may have for not being able to empty is that when you deliver a baby, kind of through that area, there's a lot of trauma and swelling to the area. So it takes a while before it's easy to pee again. Okay, so we did BU, BB. Now we're at L. L is lochia. It's bleeding like a period. Lochia actually is filled with uterine debris, amniotic fluid, and blood. And the blood comes from the area on the inside of the uterus where the placenta was attached by all those millions of little vessels. So we need that to clot up and stop bleeding. And women are women who have had a baby are very much at high risk for having a postpartum hemorrhage in that first 1 to 2 hours after delivery. Closer to delivery, the more risk they're at. So for an early hemorrhage. So it's really important to teach mom about their bleeding, what their lochia should look like. It should, and then also they are still at risk also for a late postpartum hemorrhage, which can happen 24 hours to weeks after that delivery. So again, when we send them home, they need to know about that. So when we teach, we're going to say, it's bleeding like a period. Right now, it's kind of bright red and it's moderate to heavy. It should always get lighter in color and lighter in amount. So it will go from bright red to darker red to kind of a watery pinky color to brown to white. And it in total it lasts for 4 to 6 weeks. But by that 10 days, at the same time that your uterus, you can't feel your uterus anymore, you won't have any color. So within that 10 days to 2 weeks, there shouldn't be any color. It should already be white, and then you won't really notice it anymore. But again, that uterus is still healing inside. So we want to make sure that they don't have put anything in their vagina until the doctor says it's okay. Now, small clots are okay and not uncommon, but if they pass a clot that's bigger than an egg, they need to save the clot and call the provider. So call us if they're in the hospital, save the clot, so they have to fish it out of the toilet maybe, and save it, call the provider. The provider might want to send the clot into pathology to make sure there's no retained placental pieces there. And if that would be the case, that mom would probably have to go in and have a dilatation and curettage where they go in and scrape the inside of the uterus to make sure all of the pieces of the placenta are out. So it can cause, retaining placenta piece can cause infection, and also it can cause that clot that's holding the bleeding back to pull away and then we have lots of bleeding. How much is too much? This is one of the most important things that moms need to know. If mom is saturating one pad in 1 hour, it's too much. She should call her provider. Increase in bleeding, or if it gets, more bright red in color, it could mean that mom is doing too much and she needs to put her feet up and relax, watch her bleeding, and make sure she's not bleeding, filling a pad in an hour. So that's the lochia. All right, episiotomy laceration. Episiotomies were a procedure that they used to do. You can see this cut right in the perineum. They would make a little cut right here to make more room for the baby to come out. Now, if we're patient and push against that perineum, push and relax and push and relax, it will eventually stretch out. And so the baby can come out and there's very little tearing, or there's small 1-degree lacerations there, a peri-laceration. So what they found was whenever they were doing a cut there, they were cutting way more than a tear would have been. And, then mom always had to be sewn up, and there was a lot of scar tissue, and it really, affected her. And so it came to be that now we really let there be a little tearing. If it's a nick, if it's a really small tear, they won't even repair it. It's very, very vascular in that area, and it will heal up just fine. Now, there are different degrees of laceration and episiotomy. So if it's just in this peri area, it's a 1st degree. If it goes deeper into the tissue, it is a 2nd degree, but still no muscle involvement. If it goes into the muscle, all the way to the rectum, it's a 3rd degree peri-laceration, and sometimes baby will actually blow through the rectum, and that's a 4th degree. A 4th degree is considered an operative delivery, and they have to take her back, get a GI surgeon in to basically reconstruct that rectum. And mom has to have will have to have serial colonoscopies on a regular basis to make sure it's healing okay. I've known some moms who've had to have a colostomy. Okay, did I just say colostomy, or did I say colonoscopy and colostomy? So because they needed that area to heal after they actually did the repair. So it's a really big deal to have a 4th degree. That would happen if you have a really big baby and they're coming really fast, or you had to get that baby out really quickly. So, so that is a midline episiotomy or laceration. A laceration is a tear, episiotomy is a clean cut. We don't do episiotomies much anymore. This is considered a mediolateral. It's to the side, and you would really be trying hard to get that baby out if you do a mediolateral. Those are very uncommon also. Okay. So when we are assessing that perineal area, we have mom on her side, and we separate the buttocks, and we're looking at that whole perineal and anal area. And we use Rita. Rita's in your book. And then also there's the handout, like the BUBBLEEE handout that I have for you. So it's redness, ecchymosis, edema, drainage, and then approximation. And those are the things that we assess for. And there's actually a Rita score, but really, as long as you speak to those things, that's what we're looking at. Very common to have swelling, edema, really common. Bruising, again, not uncommon at all. drainage is, up like a pussy drainage is pretty rare, again, to even though this is just a clean area and it's not even really, you're right by the rectum there. It's not, it heals so quickly that an infection is not very common at all. So, but the redness, the swelling, the bruising, definitely common. And so we put ice on the perineum 24 hours after delivery. And then after that, they can soak in a warm tub. If ice doesn't feel good, sometimes it still feels good. So I really want everybody to remind mom to go over the peri-care with them. So they should change their pad and do peri-care with every time they empty their bladder. They should wash hands before and after. The the squeeze bottle should sit by the sink so she can fill the peri bottle with warm water, then take it in to void, spray on the perineum, and then pat dry. And then we use ice. Like I said, we have Tux witch hazel pads that she can just put right on that perineum. I know they're for hemorrhoids, but they help with all swelling. And so she can put 2 or 3 just across that sore area after having sprayed with Dermaplast, which is a topical numbing spray. So all of those things together, kind of a triple cure, a really good thing. Moms are getting are they've gone through a really, it's not necessarily traumatic, but it's very it's a huge change and a traumatic 24 hours when mom has a baby. It's not that it's not a good thing, but it's a lot to deal with. And so mom is not going to be in the mental readiness for a lot of teaching. And that's why it's really good, even though somebody else has probably told her this information, it's really good to review with her several times. So doing this during the assessment is a good thing. With a C-section incision, we use Rita also. And C-section, this is a really nice looking C-section incision. They usually sew together the subcutaneous tissue and then they glue the incision, the skin closed, and it's beautiful, much nicer than with staples. And you will often notice some bruising on one side. And that was the side usually that the surgeon stands on when they're really pulling and retracting to get that baby out. And it should look just like this, not really red at all. There shouldn't be drainage, warmth, or swelling. Ice packs on the C-section incision can really help also. For comfort, we have prescribed meds, IV meds for the first 24 hours, and then narcotic pain meds afterwards. And then they need to know the signs of infection for an incision. If they have a pannus, a real overhang over that incision, you want to tuck an absorbent cloth next to the incision to help protect it from sweat. They can get it wet, even allow soapy water to run over it, but they should rinse it well and dry it really well. We want to keep that dry so we don't grow bacteria. Hemorrhoids are kind of part and parcel of having a baby. With pregnancy, there's just a lot of pressure on the anal rectal area. And so lots of pregnant women get hemorrhoids. And if they don't have them, or if they do, they're going to get worse or pop up when they push the baby out. So, and sometimes they can bother mom, be more uncomfortable than actually the perilaceration. So we want to make sure that mom keeps soft stools and don't strain, don't hold the stool in, keep taking stool softeners at home until they have more comfort. And then just the same care as we would using the spray bottle, the Ice Tux Dermaplast for comfort. And then usually there's a corticosteroid cream that you can put on internally and externally. So, and then they can soak in a warm tub 24 hours after delivery if they didn't have a C-section. The next E is extremities. And so we're going to look at the feet, ankle, legs, and you can see little Miss Puffy Toes here. Um, Women have dependent edema because pregnant women have that big belly that's putting a lot of pressure. And so the venous return just doesn't happen as well as efficiently. So they tend to have fluid in their legs, lower legs, ankles, and feet. During labor and delivery, we tend to give them a lot of fluids to support their blood pressure. And so after delivery, it can feel like they're walking on pillows. So we assess edema. We use, you know, one +1, +2, +3 edema. We talk about pitting edema. We're going to bilaterally assess pedal pulses at the same time so we can compare them too. We'll also assess for signs of a deep vein thrombosis. Pregnancy is a hypercoagulable state. Mother Nature does that so that women don't bleed to death after they have their baby. So they do tend, is that with the decreased venous return, they do tend to be at higher risk for DVT. So you want to ask them if they have any sharp pain in their calves when they're walking. Dorsiflexion is what makes that DVT hurt. You can also palpate the backs of the calves. You're feeling for a warm red raised area. So if she has any of that, after she gets home, she should call the provider. If there's any sudden shortness of breath and chest pain, she should call 911. Another thing that you can tell mom is to get rid of that extra fluid. Her body is naturally going to be, she's going to be voiding more often and sweating more in the next 2 weeks to get rid of the extra fluid. That's really normal. It's normal if she wakes up really sweaty in the middle of the night. That's what we see. And then the last stop on our tour of the postpartum assessment is emotions. Postpartum depression is a very common thing, and we want to educate on it. It feels sort of awkward to ask about this, but you have to talk about emotions when you're asking the question. So how are you feeling emotionally is probably the best way to ask it. They'll usually say, I'm feeling good, and you'll say good. And then you want to tell them around 3 to 5 days, around the time the milk is coming in or they're experiencing engorgement, you may feel weepy, have roller coaster emotions. It's called the baby blues, and it's absolutely normal. But if it lasts for more than 2 weeks, you need to call your provider. It could be postpartum depression. We now in most places do an intake assessment, an Edinburgh postpartum depression scale. And if somebody has a high enough score, they will be referred to a perinatal psychologist before they leave the hospital, so that somebody is just watching over them and making sure that their emotional health is okay. Some of the things that you can do is try to get a little time alone for yourself every day. So they need to be saying yes to the people who offer to help, and then try to get some fresh air, do some walking. That's great exercise for them. So this is just other education that we need to know to tell them. So, and those are things that we'll be talking about more as time goes on. But the stuff that I told you today is what I want you to know when you're doing the assessment. And like I said, maybe we, maybe it's the 14th time she's heard it, but that will really just help her take that in and remember it when she needs it. Thank you.